Uh, Welcome to this important session of OBS and Gynae High Yield MCQs for the upcoming exam of INI CET May 2023. This session is going to be helpful for any other exam you are going to write or you are aiming. But I have made this series of these questions keeping in mind especially the INI CET pattern. So, I am Dr. Harmeet Goel. I am your OBS and Gynae faculty and I will be discussing this OBS and Gynae High Yield MCQs for INI CET 2023 May session. Now, my first question begins, and let me tell you, I have taken all the questions from the selected topics and I tried my best to touch each and every important topic that can come in the exam. So, welcome you all to this session. My first question begins, match column A with column B. Now, in column A, it is breech, number 2, shoulder dystocia, number 3, normal delivery, number 4, lie and presentation. And the maneuvers for these conditions are Macrobert's maneuver, Prague's maneuver, Leopold's maneuver, and Ritgen maneuver. Now I am having the chat in front of me so that I can answer to your queries. So you can keep on writing the answers in the chat section. Okay. Now, if you get such a question, always try to match the condition which you know 100% sure. Like we know lie and presentation is being done by Leopold's maneuver. Okay. Number 2, we know a maneuver for shoulder dystocia. What is shoulder dystocia? Shoulder dystocia is seen in macrosomia baby, and usually what is my clinical experience is that we have seen that those patients who are unbooked, unregistered and pregnant, they land up in the labor room in the second stage of labor or in the active stage of labor. Many times we have seen we have not been able to shift the patient to the delivery table and patient starts delivering the child. Had it been your own registered or your antenatal patient, I would have performed an elective cesarean section for a macrosomia baby. Macrosomia occurs because in diabetic mother, there is hyperglycemia, and hyperglycemia, the glucose is being transferred from placenta to the fetus by a hormone that is HPL, human placental lactogen. And when the increased sugar levels or glucose is entering into the baby, fetal pancreas starts releasing insulin as early as 12th week of pregnancy. So fetal pancreas gets stimulated, there is release of insulin and utilization of the glucose, and baby puts on weight. Number 2, there is not just one action of insulin, there is another action on insulin is that is on the lipid profile or lipid metabolism. So baby puts on weight. So in these cases, the baby starts delivering, the head is delivered and the shoulders are the one which get stuck up. How do you differentiate it from shoulder presentation? Shoulder presentation, shoulder ही first deliver होता है, that is a transverse lie. And shoulder dystocia, shoulder ही deliver नहीं होता. That is what is a different. Shoulder dystocia is seen in macrosomia diabetes where head is born and shoulders are the one which is stuck up. And shoulder presentation is a transverse lie because the arm is most unsupported part of the baby in a transverse lie condition. So lie and presentation is Leopold's maneuver. Shoulder dystocia is Macrobert's maneuver. Normal delivery is Röntgen and breech is Prague's maneuver. Okay, breech is Prague's maneuver. So let us see what is the option that is correct. 1 to C, 2 to D, 3 to A, 4 to B. So what my answer is, 1 is for B, 2 is for A, 3 is for D, and 4 is for C. So let us check which option is matching here. It is 1B, that is breech for Prague, shoulder dystocia for McRoberts, normal delivery for Röntgen, and lie and presentation is Leopold's maneuver. So such questions are being very commonly asked in INI CET exam. This pattern is usually not followed in the NEET PG style. Okay, so I hope this is so. McRoberts maneuver is for shoulder dystocia, Leopold's maneuver is for lie and presentation, Röntgen is for normal delivery, and Prague's is for breech. Let me tell you, Prague's maneuver might be asked in the question, but nowadays most of the places for a breech it is elective cesarean section, for a breech in labor is again an emergency cesarean, because the risk of breech is asphyxia, the risk of breech is conducting the breech delivery, there may be a chance for injury to the internal abdominal organs. So for breech it is a planned cesarean section or emergency cesarean section. One more reason why in breech we don't prefer to conduct a breech delivery, the chances of cord prolapse is again very high in cases of breech presentation or any malpresentation. Most common malpresentation where cord prolapse occurs is a transverse lie. Okay, so what are the conditions where cord prolapse is common? Number 1, most common is transverse lie, next is breech, then is twins, and then is polyhydramnios. So for cord prolapse, I would say always an emergency cesarean section is the best. But if the patient is full dilatation of cervix and it's a vertex presentation or it is the breech, what will be the mode of delivery? You can apply an instrumental delivery. Okay, because by the time you will prepare the patient for a cesarean section, baby will start delivering. Okay, in that case even instrumental delivery can be done if you are competent and you can apply it safely. Okay, so this is the correct answer which I have just explained. Now let us see, because in INI CET there are image based questions as well, and Leopold's maneuver is very commonly asked in any exam, whether it is NEET PG, FMG or INI CET exam. Only in UPSC exam, which is a combined medical services exam, the image based questions are not being asked. Okay, so Leopold's maneuver is first grip. First grip is called as fundal grip, where you check soft fetal parts which is non-ballotable suggestive of breech, or hard globular part suggestive of head. Second grip is called as the lateral grip. This is to check the fetal back. Third grip is the pollic grip. Pollic grip, hard globular part which is ballotable suggestive of head, or soft fetal parts which is non-ballotable suggestive of breech. This is for presentation. Head presenting, we call it as cephalic. Feet presenting, we call it as podalic. Then the fourth grip. Fourth grip is, this is fourth. Fourth grip is for engagement. Okay? If your fingers are converging, that means head is not engaged. If your fingers are diverging, that means head is engaged. So this is for engagement, and this grip is called as pelvic grip. So what are the grips? Let us see once more. First grip is the fundal grip, because they have asked question. The all four images will be given, or they can select just one image and they can ask you which grip is being applied. So that was a pattern being asked in INI CET exam. They have given this part only, and they have asked what is this grip. First grip, second grip, pollic grip or pelvic grip. So your answer is pollic grip. So third grip is the pollic grip, second grip is the lateral grip, and fourth grip is the pelvic grip. When you apply these grips 1, 2, 3 and 4 to describe the lie and presentation, this maneuver is called as Leopold's maneuver. Next, what is Mac-Roberts maneuver? Mac-Roberts maneuver is applied in case of shoulder dystocia. What is done is, baby's head is delivered and the shoulders are the one which get stuck up. Okay, which get stuck up. So Dr. Shubham, welcome. Dr. Shubham, Dr. Ritesh, Dr. Kishore, and I can see your correct answers here. Okay, so in this case there is abduction and flexion. Abduction and flexion of the lower limb of the mother. This will increase the space in the pelvis, and this will reduce the fetal shoulder girdle diameter. Okay. Now, in this case, suprapubic pressure is applied. Suprapubic pressure. So, what the nurse or the doctor is doing, they are doing the flexion of the legs towards mother's abdomen and abduction of the legs. This is to create the space in the pelvis, and she is applying a suprapubic pressure so that in order to reduce a shoulder girdle diameter of the fetus, so that the rest of the body of the baby can be delivered. Now, important question: which pressure is contraindicated in cases of a shoulder dystocia? This is an AIMS PG question. Answer is fundal pressure. Fundal pressure will cause constriction of the baby's neck, and baby will die because of asphyxia. So, suprapubic pressure you can apply, but not the fundal pressure. So, remember, Mac-Roberts maneuver is for shoulder dystocia. Now, important question: which nerve of the mother is injured or can get injured in Mac-Roberts maneuver? So, the answer to this question, can you write the answer? What is the nerve that is injured in a case of Mac-Roberts maneuver? What is the nerve in the mother? So, the answer to this question is lateral cutaneous nerve of thigh is likely to get injured in cases of Mac-Roberts maneuver. This is a question from AIMS PG. Now, I have taken a lot of time to make the PPT of this topic, so that definitely I am sure some questions will be asked in your INI CET exam, because this is very, very selected. I have tried my best to touch each and every important topic. Now, next maneuver for shoulder dystocia is Rubin's maneuver, where you can see the suprapubic pressure is applied onto the anterior shoulder in a way to reduce the diameter of the shoulder girdle. Aim is to reduce the diameter of shoulder girdle so that the baby can be delivered. Okay, if this is not successful, the next maneuver is Wood's corkscrew maneuver, where the shoulders are rotated to 180 degrees and it is the rotation of the posterior shoulder first so that the diameter of the shoulder girdle is reduced and delivery can be conducted. So you have done all these maneuvers. Suppose it fails, then what? Then they say put the fetal head back into the uterus and perform an immediate cesarean section. Well, students, if you can do it very fast, well and good. But what I have seen is, in such cases or neglected cases, usually of asphyxia or the patient coming to the hospital late, inactive or in second stage of labor, very less chance that you can save such a child. So it is always a planned cesarean section for a macrosomia baby. And how can you diagnose macrosomia baby? During pregnancy, it is by ultrasound. And what do you check is abdominal circumference of the baby more than 95th percentile for the gestation age is what is a macrosomia child. Now, this is Ridgen's maneuver. This is something which is important, and the question really I have taken a lot of time to select and to make these questions for today's discussion. Ridgen maneuver is for normal delivery, where remember the head of the baby is in flexion and maintaining the flexion of the neck, head will be borne by extension. What is the aim of Ridgen maneuver? One hand is put onto the occiput of the baby and another hand is applying at the chin of the baby in a way to control the speed of delivery. So occiput you press and the occiput will be delivered, then the vertex, then the brow and then the face. So head, the maintaining the flexion, you're delivering the baby's head by extension and adequate perineal support is given. Now why this is happening is to reduce or to prevent the chances of perineal tear. So it is to control the speed of delivery, maintaining the flexion of the neck and delivering the baby's head by extension. So Ridgen maneuver is in normal delivery. Now Prague's maneuver. Prague's maneuver was done for breech. Okay. In this case, breech baby is delivered till the neck. Now, after coming out of the fetal head of the breech has to be delivered where the occiput is placed posteriorly. The occiput of the baby is posterior. So what is done is, one hand you are holding the shoulders of the baby and you are moving the shoulder towards maternal abdomen and then dislodging the neck of the baby. The head, remember, has to be borne by flexion. So remember, Prague's maneuver is done for breech, for after coming head of breech. Okay, but nowadays the role of Prague's maneuver is limited because we do a elective cesarean section whenever there is a breech, because breech is most common malpresentation. And what is the most common complication of breech delivery is birth asphyxia or injuries to the other organs of the baby or even the bone fractures. So frankly speaking, elective cesarean section for all breech or emergency cesarean section if they come in labor. Okay. So I take my next question, and this is very important question for every exam. INI CET, many times it has been asked. NEET PG it has been asked. It has been asked in FMG exam, and again it has been asked in UPSC exam. So this is something very, very important. Which of the following, read the question very, very carefully. I have done little bit of manipulation in the question just to give you concept. In this today's discussion, my main aim is to make you revise every maximum possible question and to build up the concepts, so that, because in INI CET, remember, there can be more than one answer. So be careful about this fact. Okay, so those who have given the NEET PG and they've not been able to get a good ranking, you have an option to prepare and give your exam the best for upcoming INI CET. Which of the following is R? Whenever they give an option like is R, so that should strike your mind, there can be more than one answer which is correct. Okay, about the active management of third stage of labor. Okay, so the options given to me are uterine massage, oxytocin, early cord clamping. Okay, so in this question, I want to modify, because the original question I has given was which of the following is are correct about active management of third stage of labor, except is my question. So please mark your answers accordingly. Except, yes, early cord clamping is never done, correct. And number 2, which is wrong? Oxytocin is given, my dear friend. So uterine massage is not a part of active management of third stage of labor. It's a part for atonic PPH management. Okay, so only oxytocin is correct here. And what are the wrong options here which you have to mark is early cord clamping. So only correct answer here is oxytocin. Uterine massage is not done and early cord clamping is not done. Rather, we do a late cord clamping. Okay, so what are the paths for active management of third stage of labor? Is you have to give uterotonic, that is injection, oxytocin, intramuscular bolus. Number 2, you have to do the delivery of placenta by controlled cord traction method. Number 3, there is delayed cord clamping which is done. Now question, what is this image showing? What is this image showing? You can see that this is placenta and this hand is applying suprapubic pressure. So this is a method shown here in this image, that is controlled cord traction method. So you can get an image based question as well. Now what is the difference between early cord clamping and delayed? Early cord clamping is cord clamping done within 1 minute of delivery. Okay, and early cord clamping is done when there is birth asphyxia. When there is birth asphyxia or the baby is born in sepsis, or there is any any condition which requires a neonatal resuscitation. Okay, now delayed cord clamping. What is the advantage of delayed cord clamping? Delayed cord clamping is done within 1 to 3 minutes, and the around 80 to 100 ml of extra blood can go from mother to fetus. Okay, so that is what is an advantage. So what is this shown in this image? In this image, it is uterine massage which is shown. Okay, in this image, the uterine massage is shown. Okay, so this is uterine massage, which is management for atonic PPH. This image is showing controlled cord traction, and this is active management of third stage of labor. Now my question is, why oxytocin is preferred for as a uterotonic in active management of third stage of labor? Because onset of action of oxytocin is fast and usually there is no side effects. Number 3, it is very cheap drug and availability is not a problem. That is why oxytocin is a drug of choice for active management of third stage of labor, for atonic PPH management as well. Okay, it is also an important drug for breast engorgement, because when you give oxytocin, it will cause contraction of the breast and ease the milk release. Also, it is an important drug for induction of labor or augmentation of labor. So these are the advantages of oxytocin. Next, match the following. Friends, always expect, nowadays there is so much about STI or RTI. This is a favorite question, that is Suraksha Clinic. Okay, so it is sexually transmitted infection or reproductive tract infection. Okay, now there is a kit coordination, and in the November exam there was a question on this color code kits. Okay, in the NEET PG exam also there is a question on the color code kits, but here I have just created a question like this. Is a question of INI CET pattern where you have to match the following. So even if it is a single question, okay, so yes, Dr. Shubham, you are correct. So you are able to mark. So kit number 1, you have to match kit with a symptom. So let's find out which is the correct option. Kit 1 is for, always remember, urethral discharge. That is for cervicitis. Okay, cervical erosion, mucopurulent discharge, or like urethral discharge. So that is cervicitis. Okay, what are the causative agent for cervicitis? It is either chlamydia or it is gonorrhea. Okay, number 2, kit number 2 is for vaginal discharge. Causative agent for this is called as vaginitis, and the causative agent for this is trichomoniasis, candidiasis, and bacterial vaginosis. So this is green color kit for vaginal discharge. Then there is kit number 3. Kit number 3 is for non-herpetic genital ulcer. Okay, kit number 4. Kit number, let's take this question. Kit number 6 is for PID. Okay, there is lower abdominal pain. This is for PID. Most common causative agent for PID is chlamydia. Next is gonorrhea. Then all the causative agent for bacterial vaginosis. So all these written here, these are the causative agents for PID as well, and PID usually leads to blockage of the fallopian tube, so the presentation of the patient can be infertility. Okay, now let us see which is the correct answer. A is matching with 2, B is matching with 3, C is matching with 4, and D is matching with 1. So A2, B3, C4 and D1. 1 is the correct answer. Right? All this is clear to you? Now you should know the CDC criteria for PID. And according to CDC criteria, there is minimal, additional and definitive management. You should know the questions can be asked. But the concept of STI or RTI and this kits is minimum investigation and maximum treatment. Okay, so don't waste your time in investigating the patient. If you are clear about the symptoms, give the kits. Okay, and this is containing the broad spectrum drugs. Like kit number 1 is for urethral discharge, that is cervical discharge, which is grey color kit, which contains azithromycin and cefixime. Vaginitis is kit number 2, which is green color, fluconazole for candidal infection. Sacnidazole is for bacterial vaginosis and trichomoniasis. Genital ulcer herpes is white color kit, which is containing benzathine penicillin. Then if the patient is allergic, then you can give blue color kit, that is doxy and azithro. Then genital ulcer is red color kit, which is acyclovir. PID is yellow color kit. For gynae, remember yellow color kit, which is for PID. For gynae, it is like grey color kit for cervicitis and green color kit for vaginitis. Inguinal buboes, it is black color kit containing doxycycline and azithromycin. Okay, so usually as a gynecologist, it is grey color kit, kit number 1 for cervicitis. Kit number 2 is green color kit for vaginitis, and kit number 6, that is yellow color kit for PID. Rest is usually being dealt by the venereal disease specialist, that is the skin specialist. Okay, or even in the PSM, this is important. Fine. For us as a gynecologist, 3 kits are important. Does not mean that herpetic and all. When we see herpetic ulcers and all, we or inguinal buboes, we do refer them to the venereal disease specialist, that is dermatologist. They are the best ones to deal with those cases. Fine. So I hope this is clear. Simple, crisp revision, but with concepts. Okay, not single liners. Here single liners will not work. Fine. So this is the correct answer. Okay, fine. Next. So here also I have made this table. I have made it myself. That is urethral and cervical discharge, kit number 1 grey. You can quickly mug up this way. Vaginal discharge, kit number 2 green. Non-herpetic ulcer, kit number 3 white. If it is allergic, then blue. Herpetic ulcer is red. PID is yellow, kit number 6, and kit number 7 is black for inguinal buboes. Okay, so tried my best to give as much as content to you, as much as possible. So I hope there will not be any doubt in your mind regarding this question. Next. So this I have already explained. The causative agent for vaginitis is trichomoniasis. Then next is candidiasis, and the third one is bacterial vaginosis. Here it is chlamydia and gonorrhea. Important thing is trichomoniasis. Remember, it is thin green color vaginal discharge. Itching is the most common symptom, and there is multiple strawberry spots in vagina, and drug of choice is metrogel. Candidiasis, it is thick cottage cheesy discharge. Bacterial vaginosis, causative agent is Gardnerella, and there is no itching. It is not STD, but clue cells are seen. There is fishy odor vaginal discharge. Emsell's criteria are seen. Metronidazole is the drug of choice, and there is whiff test which is positive. That is, you take the discharge on a slide, put QH, there is a fishy smell. That is what is a whiff test. EMSA's criteria is all this. And remember, pH is more than 4.5 and there is no lactobacilli. Because if there is lactobacilli are replaced by Gardnerella vaginalis and other organisms. So their pH whenever changes to alkaline, the growth of these organisms is favored. So remember, there is no itching and it is not STD. Okay, so treating the partner is not important. Treating the partner is not important. Fine. Next. So always there is a question from vaginal discharge topic. Now analyze the hormonal profile of a 25-year-old female who has presented with amenorrhea. Okay. Whenever a female presents with amenorrhea, always do urine pregnancy test to rule out pregnancy. Okay. Suppose you have done urine pregnancy test and it is negative. Now what can be the differential diagnosis, main differential diagnosis for a female presented with secondary amenorrhea? Okay. So it can be at the level of the uterus, which can be Asherman syndrome. Like if you have done MTP or curettage, there is formation of adhesions between anterior and posterior uterine wall, and presentation of this can be menstrual disturbances like oligomenorrhea or hypomenorrhea or secondary amenorrhea, or it is infertility. Asherman syndrome, the first investigation you would like to do is HSG, where you see irregular filling defects, and the gold standard is hysteroscopy. Next is ovarian, that is compartment number 2. Here, most important cause for secondary amenorrhea lies, that is polycystic ovarian disease. Okay. Next cause can be primary ovarian insufficiency or premature ovarian failure, or at the level of pituitary, it can be Sheehan syndrome or hyperprolactinemia. At the level of hypothalamus, there is GnRH deficiency because of stress, exercise, anorexia nervosa, etc. Okay. Now, let us see which hormonal profile matches here. So, first of all, you will get a urine pregnancy test done. Then you give progesterone challenge test and look for withdrawal bleeding present or absent. Simultaneously get the hormonal profile done, where important 4 hormones are done. TSH, prolactin, because these are the 2 important systemic disorders for secondary amenorrhea. So serum prolactin and TSH are the must investigation to be done. The next is the FSH and LH levels, and the 5th hormone that you can get it done is the serum estradiol levels. So let us see which option is matching which. So I've given you the concept. Let us match the options. You know, in Sheehan syndrome, there is postpartum pituitary necrosis. So all the hormones from anterior pituitary will be down. FSH, LH, prolactin, ACTH, TSH. So सारे hormones decrease हो जाते हैं. So सबसे पहले Sheehan syndrome को match करते हैं. Easier for us to match. So here it is matching with number 3. So D I have got is number 3. Next is Asherman syndrome. Asherman syndrome, the cause is at the level of uterus. There is formation of adhesions. So hormonal profile, my dear friends, will be absolutely normal. Let us talk about 3 hormones: FSH, LH and estrogen. In this, ovaries functioning is normal, but end organ defect, that there is no endometrial lining, it has been destroyed. So FSH, LH, estradiol all will be normal. So this premature ovarian failure, Asherman syndrome is matching with this one. Okay, so I have got B option as 2. Now I will look for the premature ovarian failure, easier for me, because the ovarian follicles are depleted, so there is no ovulation and estrogen and progesterone is down, so there is no negative feedback inhibition at the level of pituitary. Pituitary does not know what to do, it keeps on secreting high FSH and high LH. So premature ovarian failure is high FSH and high LH. Now in C, I have got an answer 1. So I am left with A. A is 4. Let me mind you, in case of PCOS, it is the LH level which is high and there is a progesterone deficiency. FSH and estradiol levels may be normal. Okay, so it is eugonadotropic eugonadism. Okay, so PCOS is this one. Fine. So what is the correct match? Let us see. A goes for 4, B goes for 2, C goes for 1 and D goes for 3. Let us check once more. A is 4, B is 2, C is 1 and D is 3. I hope this is getting clear to you. Even if in the question there is a single question and answer, like they have asked what is the hormonal profile for premature ovarian failure or premature ovarian sufficiency, the correct answer is FSH more than 40 international units and serum estradiol is less than 225 picogram per ml. So it is FSH and estradiol levels which are being done for primary ovarian insufficiency or primary ovarian or premature ovarian failure. Next. Now let me quickly in a very simplified manner, what is secondary amenorrhea? Amenorrhea for 6 months or more in a previously normal menstruating female in the absence of pregnancy. Always pregnancy is a physiological cause that should be ruled out first. Okay, or you can say amenorrhea for 3 consecutive cycles. Okay, then also it is called as amenorrhea. Now important compartments, this is secondary amenorrhea and I have made this flowchart myself. Compartment 1 is uterus and its outflow tract, so there is Asherman syndrome or acquired cryptomenorrhea. Compartment 2 is ovary, where there is polycystic ovarian disease, premature ovarian failure, radiotherapy or surgery. Compartment 3 is hyperprolactinemia or pituitary adenoma or Sheehan's. Compartment 4 is GnRH deficiency. So each step you should be ruling out the important causes. Okay, so here the hormonal profile, I have just matched it for you. So I hope there is no doubt about this particular question. Even if the single questions are asked, you are able to answer them perfectly. Okay, I hope I am very clear about these problems. So Dr. Kishore, you have asked me a question, how to differentiate between a vaginal discharge or a cervical discharge. Basically, you have to go for a per speculum examination. If the mucopurulent discharge is coming from the cervix, then it is cervicitis. If on the vaginal vault, you can see there is a cottage cheesy appearance, that is, it is candidal infection. If it is strawberry spots, you can see, then it is trichomoniasis. And if it is no itching, and there is, like in the microscopy, you can see clue cells, that is a vaginal epithelial cells where bacteria are attached, then it is bacterial vaginosis. And you can do a slide test by the amine test or a whiff test. So you can differentiate the type of discharge. Fine. Next. So correct answer is A in this case, which I have already mentioned. So just to make it simplified, because students later on they say कि हमारे पास PDF नहीं है and all that, so you can pause the video and you can have a look and write down your answers, because this is very, very selective. I'm giving you a guarantee some questions will be definitely asked from today's discussion. So PCOS is FSH normal, LH high. This is important. Asherman syndrome is all normal. Premature ovarian failure is FSH high and estradiol down, and Sheehan syndrome is all down. So just to make it easy for you, I have done match the following. This question has already been asked in INI CET exam, and I am taking last 3 years pattern. Last 3 years pattern. Fine. So let me proceed further. Next, this way it will be very helpful, this whole video for you. Okay, and you will gain your confidence because majority of the things you already know. An intern conducts the delivery. Question of INI CET. An intern conducts the delivery. Immediately after delivery, the mother experiences breathlessness, hypotension, tachycardia, collapse. Per vaginum examination is normal and there is no excessive bleeding. So already PPH has been ruled out. And when there is a per vaginum examination or local examination, even they have ruled out vulval hematoma. When per abdomen examination is normal, they have already ruled out uterine inversion. Okay, so it is not PPH, it is not uterine inversion, and usually DIC do not present like this, and there is no history written in the question that it was a case of abruptio, because DIC in obstetrics, the most common cause for DIC is abruptio placentae. Okay, so this question, the typical statement, patient experiences after delivery breathlessness, hypotension, tachycardia and collapse. This is nothing other than amniotic fluid embolus. Because in amniotic fluid embolus, patient has delivered, suddenly she started gasping, breathlessness, tachycardia, collapse and gone. And you're trying to find out the cause. 2-3 cases has happened to me when I was doing my post-graduation in Obs and Gynae from VMMC Safdarjung Hospital. There we saw 2-3 cases just like that. You are trying to rule out the cause of PPH, the vulval hematoma, uterine inversion, and you're suddenly calling for help. You're putting up an IV cannula, you're calling the medicine help, you're calling the anesthetist because patient needs to be intubated and shifted to the ICU. In spite of all these efforts, the patient is gone. So it is amniotic fluid embolism and the cause is usually cardiopulmonary arrest. Fine. Now, 3 single liners which is very, very important. A lady delivered a child and went into shock. So most common cause is postpartum hemorrhage. A lady delivered a child and went into shock, which is out of proportion of blood loss. This is acute inversion of uterus. A lady delivered a child and went into unexplained shock. This is unexplained. So it is amniotic fluid embolism. I hope these 3 important single liners are clear to you, because it is something which is very, very important. Okay, this is something which is very, very important. Okay, lady delivered a child and went into shock, postpartum hemorrhage. Okay, and atonic PPH. Lady delivered a child and went into shock, which is out of proportion of blood loss. मतलब इतना ज़्यादा blood loss भी नहीं है, फिर वो shock में क्यों है? Because that is neurogenic shock. But what is the cause of death in acute inversion is finally hypovolemic shock. Okay, here the management is blood transfusion will not help. Of course, that is a supportive measure you have to give, but the management is taking the consent, shifting the patient to the OT and performing the Johnson's maneuver. What is the Johnson's maneuver? Catch hold of the uterus under GA. Patient is been anesthetized. You reposit the uterus back into its anatomical position. Okay, and then you give the uterotonic agents so that uterus contracts, because you don't want your patient to die of postpartum hemorrhage. So blood should be arranged, but you don't wait for the blood to come in these situations. Try to reposit the uterus back into its anatomical position followed by uterotonics. That is what is the management of acute inversion of uterus. I hope I am making the things very, very clear, because these are the questions which they tend to ask in your exam. So let me take up one more new question, that is 35-year-old female, second gravida, para 1 L1 with the previous normal delivery, now comes in the third trimester for antenatal checkup. Her blood pressure is 150 by 110 and there is proteinuria plus. Nowadays, proteinuria has not been important when you want to categorize a mild preeclampsia or a severe preeclampsia. It is the blood pressure which is the first and foremost differentiating feature. And number two, it is the end organ damage. That is headache, which is a cerebral symptom, visual disturbances, that is blurring of vision. There can be epigastric pain. Okay, so all this is important. Plus the lab investigations of platelet count decreasing, LFT deranged, serum creatinine rising, peripheral smear shows hemolysis. These are the features of end organ damage. Now, what are the symptoms of imminent symptoms of eclampsia except headache is a symptom, vomiting, epigastric pain, but pedal edema is not a symptom. Okay, it will not describe the severity and neither it is a sign or symptom of impending eclampsia. Okay, if you don't control the blood pressure, she will throw the fits. Now, what is important? What is a drug of choice for hypertension in pregnancy? Hypertensive crisis in pregnancy. So the answer is no other than labetalol. Although hydralazine is also a safe drug, nifedipine is also a safe drug, but onset of action of labetalol is fast. Number two, we can start in acute emergency with a 20 milligram or 40 milligram IV dose, and every 10 minutes we can increase 20-20, 40 का 80 कर देते हैं, 80 का 160 कर देते हैं. So in 1 hour time, maximum dose we can give is 220 milligram of labetalol. So its onset of action is fast, it is safe drug, and it is not a teratogenic effect. Now, which antihypertensive is contraindicated? Of course, this ACE inhibitor is contraindicated. All of you know. In first trimester, you can't give because it causes teratogenic effect, congenital malformation. In second trimester, third trimester, you can't give because it causes placental insufficiency and fetal hypoxia. तो फ्रेंड्स, हम एस इनहिबिटर किसी भी ट्राइमेस्टर में नहीं दे सकते. फर्स्ट ट्राइमेस्टर में ये कंजेनिटल मैलफॉर्मेशन करता है, सेकेंड एंड थर्ड में प्लेसेंटल इनसफिशिएंसी, हाइपोक्सिया, ओलिगोहाइड्रमनियोज, आईयूजीआर एंड आईयूडी करता है. ठीक है, सो एस इनहिबिटर इज स्ट्रांगली कॉन्ट्रा इंडिकेटेड. सो एक्लेम्सिया, प्री एक्लेम्सिया पे एक क्वेश्चन तो डेफिनेटली आ रहा है इन INI CET एग्जाम. सो एंड ऑर्गन डैमेज मैंने बता दिया. प्लेटलेट काउंट लेस देन 1 लाख पर क्यूबिक मिलीमीटर. पेरिफेरल स्मीयर कैन शो hemolysis, creatinine is rising, liver enzymes deranged, and LDH is elevated. These are the features or lab findings of end organ damage, and NST, that is non-stress test, can show fetal heart rate decelerations because of fetal hypoxia. So monitoring of NST is very important. So what are the parameters in the fetal monitoring which is important? Is NST at least weekly or bi-weekly it should be done, then biophysical profile, and then Doppler ultrasound if there is associated IUGR. So these tests are for fetal monitoring. Blood investigation, fundus eye examination. Fundus eye examination is again important for eye ophthalmological changes. If there is papilledema, there can be a feature, there can be a retinal detachment. So termination of pregnancy should be strongly considered. Next, the investigation of choice in a 55-year-old postmenopausal woman who has presented with postmenopausal bleeding. Postmenopausal bleeding should be taken very, very seriously. And the first investigation, what will you mark? Pap smear, fractional curettage, transvaginal ultrasound, or CA125. CA125 is out of my list. Okay. Fractional curettage is a invasive investigation, although it is a gold standard, but it is not done as a first investigation. Pap smear is mandatory in every female, whether it is premenopausal, whether reproductive age group, or whether it is postmenopausal, it is recommended. So pap smear is anyways done, but here the most important cause, senile endometritis, I want to rule out. So my first investigation for a postmenopausal bleeding will be a transvaginal scan. Okay, so transvaginal scan for postmenopausal bleeding. Okay, and I would like to check for endometrial thickness. If endometrial thickness is less than 4 mm, that is cutoff limit for endometrial thickness in a menopausal lady, I am going to put my patient on follow-up. If endometrial thickness is coming to be more than 4 mm or her bleeding is persisting, I am going to do the investigation, and investigation of choice is endometrial sampling. In other countries, they use it with a pipple like office endometrial biopsy. Okay, but we do it as endometrial aspiration cytology, combine it with endocervical curettage. I am going to take the Carman's cannula and take the sample in this Carman's cannula and send it for histopath. This is EA sample. But what is the first sample I should be taking? I will take a curette and gentle curettage. I will do it in the cervical canal. And this is ECC sample, because cancer in the cervical canal is adenocarcinoma and cancer in the uterus is adenocarcinoma. तो मुझे 2 सैंपल लेने हैं. इस इन्वेस्टिगेशन को हम क्या बोलते हैं? EA प्लस ECC. तो पहला इन्वेस्टिगेशन मुझे क्या लेना है? ECC, सर्वाइकल क्यूरेटाज सबसे पहले लेते हैं, फिर उसके बाद मैं EA लूँगी. तो इसको मैं सैंपल नंबर 1 एंड सैंपल नंबर 2 सेपरेटली लेबल कर दूँगी एंड सेंड इट फॉर हिस्टोपैथोलॉजिकल एग्जामिनेशन. ठीक है. इफ सपोज EA and ECC report comes normal, but patient's bleeding is persisting, then I will go for a gold standard investigation, that is fractional curettage, जिसमें कि more than one area से हम sample लेते हैं, एंडोसर्विक्स, isthmus, fundus, uterine walls. So हमने सारे areas से sample ले लिया. It is a better investigation and we can arrive at a diagnosis. If suppose my patient, the report comes like focal endometrial thickness, or there is some space occupying lesion, or there is some pyometra. So in that case, I will go for hysteroscopy, because hysteroscopy का क्या फ़ायदा है, एक तो मैं पूरा यूट्राइन कैविटी विजुलाइज कर लूँगी, एंड वेयर एवर देर इज़ अ सस्पिशियस एरिया आई कैन टेक बायोप्सी फ्रॉम एनी सस्पिशियस एरिया. स्टैंडर्ड फॉर हिस्टोपैथ. अगर कोई पॉलिप होगा तो मैं पॉलिपेक्टमी कर दूंगी एंड सेंड इट फॉर हिस्टोपैथ. ठीक है. सो हिस्ट्रोस्कोपिक गाइडेड बायोप्सी. ठीक है. सो दिस इज एंडोमेट्रियल पिपल एंड इट इज यूज्ड फॉर एंडोमेट्रियल सैम्पलिंग. ठीक है. और ऑफिस एंडोमेट्रियल बायोप्सी. ठीक है. दिस इज एंडोमेट्रियल एस्पिरेशन. दिस इज कार्मन्स कैनुला. ठीक है. सो मैंने पिपल भी दिखा दिया, कार्मन्स कैनुला भी दिखा दिया. ठीक है. एंड हिस्ट्रोस्कोपी मैंने एक्सप्लेन कर दिया है. अगर कहीं पे फोकल थिकनेस है या स्पेस ऑक्यूपाइंग लीजन है, सो आई एम गोइंग टू गो फॉर हिस्ट्रोस्कोपिक गाइडेड बायोप्सी फ्रॉम सस्पिशियस एरिया. ठीक है. अगर कोई पॉलिप है तो आई विल डू पॉलिपेक्टमी एंड सेंड इट फॉर हिस्टोपैथोलॉजिकल एग्जामिनेशन. ठीक है. नाउ नेक्स्ट, विच ऑफ द फॉलोइंग इज यूज्ड फॉर प्यूबर्टल डेवलपमेंट. कौन सी स्टेजिंग हम यूज करते हैं प्यूबर्टल डेवलपमेंट के लिए? टेनर्स, पेजेस, फेरीमैन गैल्वे और शेयर्स. Which classification or staging is used for pubertal development? What is your answer? What is your answer? Dr. Kishore, Dr. Shubham? Yes. So what is your answer? Yes, I'm happy. Shipra, another one candidate, she's appeared and given the correct answer. And Dr. S, Dr. AG, and I can see many others are writing the correct answer. So it is a Tanner's classification. Friends, let's review. Tanner's is for puberty changes. What is the first sign of puberty in a girl? Answer is increase in the growth spurt. Okay. First visible sign of puberty in girls is thelarchy. Hormone responsible for thelarchy: estrogen. First puberty sign in boys: increase in testicular size. ठीक है. So first sign of puberty in girls is growth spurt, but friends, that is not visible. Okay. So visible sign of puberty in girls is thelarchy. Hormone responsible for thelarchy is estrogen, and first sign of puberty in boys is increase in the testicular size. Now, Page's classification is for grading of abruptio placentae. Ferryman Galway is for hirsutism. And Scher's classification is again for abruptio placentae. So Tanner's is for puberty changes. Fine. I hope it is getting clear to all of you. So Tanner's is the answer. Tanner's for puberty changes, Page's is abruptio, Ferryman Galway is for hirsutism, Scher's is for abruptio. Okay. Now for placenta previa, what is the regime? Answer is McCafe Johnson's regime or conservative management. Okay. Now, the sequence of puberty in girls is growth spurt. This is according to our standard textbook Novak Gynae. Okay, that we read in postgraduate. So growth spurt, but that is not visible. Next is thilarchy. Then there is pubic hair. Then there is axillary hair. Then there is peak height velocity, and then there is menarche. So remember this sequence, which is very, very important. One more question which is important is that testis started secreting hormone in the 7th week of pregnancy. So it has Sertoli cells which secrete androgen binding protein. It secretes inhibin and it secretes Mullerian inhibiting substance in the intrauterine life which inhibits the development of Mullerian duct. अगर ये हार्मोन सिक्रीट नहीं होगा तो क्या होगा बॉयज में? यूट्रस भी प्रेजेंट होगा. ठीक है. सो मुलेरियन इनहिबिटिंग सब्सटेंस इज इंपॉर्टेंट. सो सर्टोली सेल सिक्रीट एंड्रोजन बाइंडिंग प्रोटीन इनहिबिन एंड मुलेरियन इनहिबिटिंग सब्सटेंस. और इसमें कौन से रिसेप्टर्स होते हैं? FSH रिसेप्टर्स. ठीक है. ऑन द अदर हैंड देयर आर Leydig cells and they have receptors for LH. ठीक है. They have receptors for LH. ठीक है. And it secrete testosterone. Let me tell you, testosterone is very, very important in the intrauterine life for the external and internal genital organs development in the male fetus. Fine. Now let's proceed further. This is Tanner's classification. कुछ इस तरह की classification होती है. Breast, axillary hair and pubic hair. Breast development, axillary hair and pubic hair. So there are 5 stages in the Tanner's classification. Okay. Next, which of the following is not a component of biophysical profile? Kick movement, fetal tone, NST, amniotic fluid. So kick movement हम पूछते हैं, but it is not a component of biophysical profile. There are 5 components. Biophysical profile is a special ultrasound done in high risk pregnancies, and we check 5 different fetal parameters. That is NST, non-stress test, which is relationship of fetal heart rate to fetal movement. So normal fetal heart rate is between 110 to 160 beats per minute. Less than 110 is fetal bradycardia. More than 160 is fetal tachycardia. Both means fetal distress. Next is amniotic fluid. The abdomen is divided into 4 quadrants and you check the Leica pockets. Then fetal tone. Normally fetus is flexed to at least one movement. So 20 to 30 minutes आप ultrasound करते हैं and you check these 5 different fetal parameters. Then there is fetal breathing movement. Fetal breathing movement. And then there is gross body movement. तो सबको हम स्कोर देते हैं. सबको हम स्कोर देते हैं 2 to 2. So normal score is 10 by 10. That means the baby is absolutely fine. So ये कौन से केसेस में हम करते हैं दिस बायोफिजिकल प्रोफाइल? Biophysical profile is done in high risk cases like post-dated because there is risk of meconium aspiration. It is done in preeclampsia. It is done in IUGR. It is done in chronic hypertension, or it is done in diabetics because there is a chance of fetal loss. ठीक है, या तो 0 स्कोर होता है या 2 स्कोर होता है. ठीक है. नेक्स्ट, which of the following investigations are helpful in diagnosing a unicornuate uterus? Unicornuate uterus, usually there are two Mullerian ducts. They fuse to form a single uterus, fallopian tube, cervix and upper part of vagina. From below the urogenital sinus, it forms the bladder and it forms the lower vagina, and the canalization of the uterus takes place, and this cavity is a single cavity ठीक है. So by 20 weeks vaginal canalization takes place and cervical septum is uterine septum is resolved. When there is any defect that leads to Mullerian duct anomalies, so unicornuate uterus is one of the uterine anomaly. So unicornuate uterus we will be able to diagnose by HSG, hysterosalpingography, and another investigation where you can confirm is by laparoscopy, or nowadays investigation is 3D ultrasound if you talk about non-invasive investigation or MRI. So 3D ultrasound हम prefer करते हैं, but here 3D ultrasound or MRI is not given, so HSG and laparoscopy are the correct answers. So answer is HSG and laparoscopy. This is from INI CET exam. Okay? Clear? Now another question I have taken up. 25-year-old female present with infertility. Semen analysis is normal. Female gives history of unilateral dysmenorrhea. Remember unilateral dysmenorrhea, I told you it is a simple feature of a unicornuate uterus. हमेशा unilateral एक साइड dysmenorrhea हो रहा है, ये हमेशा फीचर होता है unicornuate uterus where there is rudimentary horn and there is non-communication with uterine cavity. मतलब एक साइड के कॉर्नुआ ने फेलोपियन ट्यूब भी बना दिया, यूट्रस भी बना दिया, दूसरा कॉर्नुआ जस्ट आके अटैच हो गया है, लेकिन उसमें कोई भी कम्युनिकेशन नहीं है. तो होगा क्या, जब हार्मोनल चेंजेस हो रहे हैं एंडोमेट्रियल लाइनिंग यहाँ पे भी बन रही है, ठीक है, यहाँ पे मेंसेस होगा, यहाँ पे भी एंडोमेट्रियल लाइनिंग बनेगी, लेकिन यहाँ का ब्लड कहीं बाहर जा नहीं सकता तो यहीं पे कलेक्ट होगा, तो ये यूनिलैटरल डिस्मेनोरिया करता है. अब अगर दूसरी कंडीशन जिसमें कि दिस इज अ हॉर्न, सिंगल हॉर्न, ठीक है, एंड हेयर देयर इज अनदर हॉर्न बट दिस कैविटी is communicating with this, तो होगा क्या, this ovum is released and this fimbria has picked up and there is fertilization. So this fertilized ovum, instead of going to the uterus, it has got into this side. So this is ectopic pregnancy and it is very, very difficult to manage. So pregnancy occurring in the rudimentary horn of the यूट्रस. तो अगर कम्युनिकेशन है तो एक्टोपिक प्रेगनेंसी का चांस है, अगर कम्युनिकेशन नहीं है तो यूनिलैटरल dysmenorrhea. So this feature is unicornuate uterus. History से भी and examination part से भी we can see. ठीक है, तो आप देख रहे हो इसमें एक ही कॉर्नुआ दिख रहा है, देयर इज जस्ट वन साइड. ठीक है, fine. Next, HSG shows unicornuate uterus. I have just explained. When the horn is not connected to the rest of the cavity, functional endometrium gets collected, leading to unilateral dysmenorrhea. I have just explained. Chance of ectopic pregnancy if horn gets connected to the uterine cavity. तो इसमें अगर if not connected, then unilateral dysmenorrhea. If connected, then the risk of ectopic pregnancy is increased. So these are the two important complications of a unicornuate uterus. Next, this is the classification for Mullerian duct anomalies. Class 1 is Mullerian agenesis. Class 2, Mullerian agenesis means uterus absent and ovary present. Uterus is derived from Mullerian duct, ovary arises from genital bridge. So breast development is normal, axillary pubic hair is normal, but she will not menstruate primary amenorrhea because there is no uterus. Class 2 is unicornuate uterus. You have to remember this classification. Class 2 is unicornuate, class 3 is didelphus, class 4 is bicornuate, class 5 is septate. Most common uterine anomaly is septate uterus. Most common uterine anomaly causing habitual abortions or causing infertility is septate uterus, and next is bicornuate uterus. Pregnancy goes uneventful in which type of the uterine anomaly? Arcuate uterus. So it is like pregnancy reproductive outcome is best. So pregnancy can easily occur in arcuate uterus because arcuate uterus there is just a dome shaped depression. ठीक है, so सबसे बेस्ट रिप्रोडक्टिव आउटकम किसका होता है? आर्कुएट यूट्रस का. देन क्लास 7 इज DES रिलेटेड. ठीक है, DES रिलेटेड पे देयर वाज अ क्वेश्चन इन द PG एंट्रेंस. सो मुलेरियन एजेनेसिस इज क्लास 1, class 2 is unicornuate, class 3 is didelphus, 4 is bicornuate, 5 is septate, 6 is arcuate, and 7 is DES related. So this is given in your undergraduate textbook Shaw's Gynae, so you must read this. Fine. Next, all of the following can cause non-immune hydrops fetalis except non-immune hydrops fetalis. Torch infection is very important cause. This is called as non-immune hydrops fetalis, and immune hydrops fetalis, which is the cause? RH incompatibility. ठीक है, so कौन सा टॉर्च इन्फेक्शन डज नॉट कॉज नॉन इम्यून हाइड्रोप्स फिटालिस? सो द आंसर इज HIV. HIV do not cause non-immune hydrops fetalis, and HIV do not cause any congenital malformation in the fetus. Okay, HIV causes failure to thrive. If the mother is HIV positive, the risk of transmission to the fetus is 30%, and maximum is at the time of labor or at the time of delivery. Okay, now if mother is HIV positive, then you have to start antiretroviral therapy immediately and give it for lifelong. What do you give to the baby? Nevirapine. बेबी बॉर्न टू HIV मदर, विच एंटीरेट्रोवायरल ड्रग इज गिवन? नेविरेपिन. ठीक है. सो HIV ट्रांसमिशन फ्रॉम मदर टू फीटस इज 30%, मैक्सिमम इज ड्यूरिंग डिलीवरी. सो अगर मदर को HIV पॉजिटिव है, इररिस्पेक्टिव ऑफ द CD4 काउंट, irrespective of the trimester, immediately start antiretroviral therapy and give it lifelong. Remember, HIV again is not a indication for compelling the patient for MTP. It is not an indication. ठीक है. So this is hydrops fetalis. The fetus is born. You can see there is generalized anasarca, there is hepatosplenomegaly, there is ascites, all this, and this is the because of infection there is bone marrow suppression, so there is hydrops fetalis, and this is the X-ray of hydrops fetalis. Now these are some of the causes for non-immune hydrops fetalis. Cardiovascular is arrhythmias, myocardiopathies, abstain anomaly causes the hydrops fetalis. Then genetic, there is myopathies, there is metabolic disorders, autoimmune diseases, trisomies, all Turner trisomies, etc. are the causes. Then congenital infections like torch infections, cytomegalovirus, parvovirus is very important cause for hydrops fetalis. Non-immune anemia, alpha thalassemia, twin transfusion syndrome. So you should be able to revise this. This is important. The causes are very important. Okay. Next question. And also there are some miscellaneous causes as well. You can go through the slide later on. Now, cancer caused by DES exposure. This is INI CET exam question. And it is AIMS PG question. It has been asked in NEET PG question. Cancer caused by DES exposure. In the olden times, there was high dose of estrogen given as an post-coital contraception or emergency contraceptives. DES, if she has taken, and if the child born is a female child, then there can be vaginal problems and cervical problems. If the child born is a boy, then also there is DES in exposure which can affect the male fetus as well as the female child. So what is your answer? I can see Dr. Kishore, Dr. Deepak, Dr. Sadhna. The correct answer is clear cell carcinoma of vagina. This is something which is important. So please pay attention to my next slide, which is important, like DES exposure. And if the child is a female, what kind of malignancy can occur? Clear cell adenocarcinoma of the vagina and clear cell adenocarcinoma of the cervix. And what is the problem? In the uterus or cervix as such, there can be T-shaped uterus. So remember, DES exposure is class 7 of the Mullerian duct anomalies. Okay, T-shaped uterus. Uterus is almost a T-shape. Okay, there is coxcomb cervix and there is fimbrial abnormalities. That means it can affect the uterus, it can affect cervix, fallopian tube and vagina, or there can be Asherman syndrome. If it is a male child, then there is undescended testis, phimosis and male infertility. So this drug is no longer in use and use has been stopped because of all these problems. So the question has been asked on T-shaped uterus, on the male and the malignancies. Asherman syndrome, hardly they have asked any question in your exam. Next, 28-year-old female with the absence of periods for 4 months. So she has amenorrhea for 4 months. 4 months amenorrhea. There is irregular periods for past 4-5 cycles. On examination, she is overweight. Breast is normal. No hirsutism remember, no hirsutism. This is important clue. On examination, per vaginum examination is normal. All the workup are normal except which workup you will not do. मतलब एक पेशेंट है जिसको 4 months एमेनोरिया है, इरेगुलर पीरियड्स है 4-5 साइकिल से, ओवरवेट भी है यानी ओबेसिटी भी है, बट हिर्सुटिज्म एब्सेंट है. सो यू विल नॉट थिंक इन टर्म्स ऑफ पॉलीसिस्टिक ओवेरियन डिजीज बिकॉज हिर्सुटिज्म इज वेरी वेरी इंपॉर्टेंट कंपोनेंट. ठीक है, और इसमें लिखा भी है पेल्विक एग्जामिनेशन नॉर्मल है. तो कौन सा वर्कअप आप नहीं करोगे? देखो, सबसे पहले हम इसको ऑप्शन ढूंढने से पहले सबसे पहले देखते हैं. सबसे पहले आप यूरिन प्रेगनेंसी टेस्ट कराते हो. अगर प्रेगनेंसी है तो फिर प्रेगनेंसी की तरफ देखते हो. अगर यूरिन प्रेगनेंसी टेस्ट नेगेटिव है तो आप क्या करते हो? प्रोजेस्ट्रॉन चैलेंज टेस्ट करते हो. अगर प्रोजेस्ट्रॉन चैलेंज टेस्ट में विड्रॉल ब्लीडिंग आ जाता है देन इट इज एन ओव्यूलेशन, पीसीओडी. अगर विड्रॉल ब्लीडिंग एब्सेंट है तो आप ईस्ट्रोजन प्लस प्रोजेस्ट्रॉन देते हो. ठीक है, और फिर विड्रॉल ब्लीडिंग चेक करते हो. तो उसमें प्रीमेच्योर ओवेरियन फेलियर आ सकता है, उसमें एशरमैन सिंड्रोम आ सकता है, उसमें जो है हाइपर प्रोलैक्टिनीमिया आ सकता है. तो जब भी आप वर्कअप करते हो, यूरिन प्रेगनेंसी टेस्ट करा रहे हो और प्रोजेस्ट्रॉन चैलेंज टेस्ट दे रहे हो, साथ में 2 हार्मोन्स जो हमको कराने हैं सिस्टमिक डिजीज के लिए, वो हमेशा होता है आपका सीरम प्रोलैक्टिन ज़रूर कराते हैं, TSH ज़रूर कराते हैं. ये 2 इंपॉर्टेंट इन्वेस्टिगेशन है. सो इनिशियल इन्वेस्टिगेशन में मेरा यूरिन प्रेगनेंसी टेस्ट आएगा, प्रोजेस्ट्रॉन चैलेंज टेस्ट आएगा, TSH एंड प्रोलैक्टिन आएंगे. बट मैं सीधे सीधे प्रीमेच्योर ओवेरियन फेलियर नहीं सस्पेक्ट करूंगी, तो मैं कभी भी ईस्ट्राडियोल शुरू में नहीं कराऊंगी. अगर ईस्ट्रोजन प्रोजेस्ट्रॉन के बाद विड्रॉल ब्लीडिंग आ जाता है तो मैं प्रीमेच्योर ओवेरियन फेलियर या प्रीमेच्योर ओवेरियन इनसफिशिएंसी सस्पेक्ट करूंगी, जिसमें FSH एलिवेटेड है एंड ईस्ट्राडियोल डाउन है. लेकिन प्रोलैक्टिन एंड TSH आपके लिए मस्ट है. जब भी आप सेकेंडरी एमेनोरिया पेशेंट का वर्कअप करते हैं यूरिन प्रेगनेंसी टेस्ट के साथ ही आप उसको बोल देते हो कि ब्लड सैंपल दिया. इफ दैट टेस्ट इज नेगेटिव, प्रोजेस्ट्रॉन देते हो 5 days एंड स्टॉप करते हो, विड्रॉल ब्लीडिंग चेक करते हो. ठीक है, सो दैट इज अ वर्किंग अप ऑफ अ केस ऑफ सेकेंडरी एमेनोरिया. नेक्स्ट, 30-year-old फीमेल कम्स टू गायनी OPD, एब्सेंस ऑफ पीरियड्स. इसको भी सेकेंडरी एमेनोरिया है, बट इसमें हिस्ट्री है DNC फॉर मिस्ड पीरियड्स. सेकेंडरी एमेनोरिया है, इसने DNC कराया था, पहले DNC कराया, फिर इसको सेकेंडरी एमेनोरिया हो गया, फिर इसमें UPT करा, नेगेटिव है, प्रोजेस्ट्रॉन चैलेंज टेस्ट भी नेगेटिव है, कोई ब्लीडिंग नहीं है. ठीक है, इसमें TSH प्रोलैक्टिन नॉर्मल है, यानी थायराइड डिसऑर्डर हाइपर प्रोलैक्टिनीमिया नहीं है. अब इसमें FSH देखो, FSH भी नॉर्मल है. ठीक है, FSH भी नॉर्मल है. तो क्या है, जब भी कोई DNC की हिस्ट्री है उसके बाद सेकेंडरी एमेनोरिया हो गया और FSH आपका नॉर्मल आए, तो आप क्या सस्पेक्ट करोगे? एशरमैन सिंड्रोम, यूट्राइन साइनिकी. ठीक है, PCOD नहीं है क्योंकि विड्रॉल ब्लीडिंग नहीं है, पिट्यूटरी फेलियर भी नहीं है जी क्योंकि क्यूरेटाज की वजह से प्रॉब्लम है. सो द आंसर इज एशरमैन सिंड्रोम एंड द गोल्ड स्टैंडर्ड इन्वेस्टिगेशन इज हिस्ट्रोस्कोपी. सबसे पहले मैं क्या कराऊंगी? सबसे पहले मैं कराऊंगी HSG, उसके बाद हिस्ट्रोस्कोपी, बिकॉज हिस्ट्रोस्कोपी विल कंफर्म योर डायग्नोसिस and you can treat your patient, that is by adhesiolysis. ठीक है, सो यूरिन प्रेगनेंसी टेस्ट किया, नेगेटिव आया, प्रोजेस्ट्रॉन चैलेंज टेस्ट दिया, नो ब्लीडिंग. ठीक है, TSH कराया, प्रोलैक्टिन कराया, FSH कराया, ऑल 3 नॉर्मल. इसमें अगर ईस्ट्रोजन एंड प्रोजेस्ट्रॉन भी देंगे तो भी कोई ब्लीडिंग नहीं आएगा. बिकॉज यहाँ पे डिफेक्ट कहाँ है? डिफेक्ट इज एट द लेवल ऑफ यूट्रस. सो दिस इज Asherman syndrome. This is Asherman syndrome. Fine. Next. So this is HSG. You can see there is irregular filling defects, and confirmatory is hysteroscopy, because hysteroscopic guided you can do adhesiolysis. Hysteroscopic guided you can do adhesiolysis. Which of the following is not indicated in the first trimester abortion? This is INI CET exams latest MCQ. ठीक है, MVA, that is manual vacuum aspiration. Manual vacuum aspiration is done in those places in rural areas where there is no electricity facility. ठीक है, manual vacuum syringe. This is manual vacuum syringe where these are two valves operated. Its capacity is 60 cc and pressure generated by pulling this is 660 millimeters of mercury. So this is used for first trimester MTP in rural area. DNC is always a method for first trimester MTP. Mifepristone and misoprostol is used for first trimester MTP up to 9 weeks only. So ethacridine lactate was a method for second trimester but not used. For a second trimester MTP, the only method used is prostaglandins, which is safe and the effect is very, very good. So ethacridine lactate आजकल यूज नहीं करते हैं. ठीक है. So I hope this is clear to you. Next, hormonal profile in a premature ovarian failure. Premature ovarian failure का मतलब क्या है? Ovaries, there is follicular depletion. So there is no ovulation and estrogen progesterone is down. So there is no negative feedback inhibition at the level of pituitary, and pituitary secretes high FSH and high LH. So FSH is more than 40 international units and estradiol is less than 25 picograms per ml. So the best answer for this is a very, very favorite question of AIMS PG. ठीक है. So there is so much about premature ovarian failure nowadays. Now I have two more questions for you. In premature ovarian failure, जिसको premature ovarian insufficiency भी कहते हैं, premature ovarian failure, if she is presented with secondary amenorrhea, then your treatment is estrogen and progesterone. ठीक है. If she has presented with infertility, then your answer is IVF using donor oocytes. IVF using donor oocytes. Question already asked in AIMS PG. ठीक है. प्रीमेच्योर ओवेरियन फेलियर क्या है मैंने बता दिया आपको. दिस इज ऑलरेडी बीन आस्क्ड इन एम्स पीजी. हाई FSH and estradiol is down. What is the treatment of secondary amenorrhea in premature ovarian insufficiency? So it is estrogen and progesterone. If she has come up with infertility, suppose her age is 28 and infertility, using a donor oocyte, doing IVF, you can prepare the uterus by giving estrogen and progesterone, endometrial lining, get an ultrasound done to check for endometrial thickness and transfer the embryo. So IVF using the donor oocytes. Suction evacuation beta is done for OBS cases where it is MTP. Dilatation evacuation is done for MTP, but their ovum forceps are used. ठीक है. Dilatation curettage is done, DNC is done where only curate is there. This is done for gynae cases usually. ठीक है. DNC gynae cases के लिए करते हैं. Now next is a 30-year-old lady presented in gynae OPD with complaints of dysmenorrhea, painful coitus, infertility for 4 years of marriage. इसमें typical history आ रही है dysmenorrhea, young patient, painful coitus, dyspareunia, infertility. This is classical triad present for endometriosis. 4 years of marriage, infertility, she has dysmenorrhea, dyspareunia. ठीक है. Uterus is retroverted and there is tenderness in the pouch of Douglas because there is endometriotic deposits which is causing pain. So mobility of the uterus is restricted. ठीक है. TB is done 8 months back and it is all normal. What is your next line of management? Endometriosis हमने diagnosis बना ही लिया है because dysmenorrhea most common symptom, pain is the most common symptom. Then there is dyspareunia, painful coitus because of pouch of Douglas, endometriosis. Then there is infertility. So the classical triad of dysmenorrhea, infertility, dyspareunia, uterus fixed, normal size, retroverted, so it is endometriosis. I would like to go for the gold standard investigation, that is laparoscopy. Gold standard investigation, that is laparoscopy. Fine. So what is this? This is a chocolate cyst of ovary. This is most common site for endometriosis. This is pouch of Douglas, endometriosis, and there is, I can see, dense adhesions. So this is a severe form of endometriosis. ठीक है. In mild endometriosis, the treatment of infertility is clomiphene citrate plus IUI. In moderate to severe endometriosis, the treatment of infertility is IVF. So depending upon the laparoscopic finding, कि mild है, moderate है या severe है, I am going to plan the management. If she is mild endometriosis, I will try to do adhesiolysis by laparoscopy and give her a benefit of 6 months. She can try for a normal pregnancy. If she is not able to conceive, I am going to give her ovulation induction with IUI, intrauterine insemination, with a husband's or partner's prepared semen. If she is moderate to severe, I don't want to do any adhesiolysis because that can cause damage to the bladder and bowel. So I would like to go for IVF. Thank you, Dr. Rahul, for appreciating my efforts. Now, 40-year-old women, this is very important MCQ for a PG entrance. Such question they are asking even in FMG exam. This is very important. This is USMLE series also. This is DNB PG also. Of course, FMG and NEET. So very important. कोई सा भी आप exam लिख रहे हैं, ये बहुत important है. So 40-year-old female presented with intermenstrual bleeding. Intermenstrual bleeding means metrorrhagia. intermenstrual bleeding is metrorrhagia. Ultrasound shows a feeding vessel in the endometrial cavity. अगर कहीं पे भी ये वर्ड लिखा है feeding vessel, this is no other than endometrial polyp. फीडिंग वेसल टर्म एंडोमेट्रियल पॉलिप ही होता है मोस्ट ऑफ द टाइम. ठीक है. सो अगर हम इसको ट्रेस करते हैं, ये यहां से ट्रेस हो रहा है. ठीक है. सो दिस इज समथिंग विच इज स्पेस ऑक्यूपाइंग. सो ये क्या है? एंडोमेट्रियल पॉलिप है और इसकी एक फीडिंग वेसल है. सो दिस इज नो अदर. अगर मुझे ये क्लू मिल जाएगा, मेट्रोरेजिया है, 40 ईयर है और फीडिंग वेसल है with some space occupying lesion, I am going to mark the answer as endometrial polyp. It is not fibroid. Fibroid does not come with a feeding vessel because that is an outgrowth of the endometrium only. ठीक है. endometrial cancer भी ऐसे present नहीं करता है. ठीक है. So this is what is in the Doppler of feeding vessel. So this is endometrial polyp where there is intermenstrual bleeding and there is space occupying lesion in uterus with a feeding vessel. So this is endometrial polyp. And what is the treatment plan? What is your treatment plan? Next, without delay, I am going to do a hysteroscopy and followed by polypectomy, followed by histopathological examination. When I am doing hysteroscopic guided polypectomy, I want to do the curettage of the uterus and send for histopath. So separate samples I'm going to take, because if I'm doing hysteroscopy something, I'm doing it under the anesthesia. So why not take the scrapings from uterine cavity, okay, and send it for histopath to be doubly sure that there is no endometrial hyperplasia and no endometrial cancer. By taking the curettings, I am trying to rule out endometrial hyperplasia and endometrial cancer. Mind it. Fine. So I've given you many clues in these questions and all are selected PG questions, my dear friends. Some questions can be repeated. Maybe the form of questions they can change. Now next question is 35-year-old multiparous lady delivered vaginally. Doctor was trying to deliver placenta by controlled cord traction method but failed. मतलब it was now becoming a retained placenta because doctor, if try to pull the cord, it will cause acute inversion of uterus, but patient started developing excessive bleeding, so they are not able to take out the placenta. This is now 3rd stage PPH because she has developed excessive bleeding. So she is shifted to OT. Shift to OT, where doctor performed manual removal of placenta under GA but failed. So what can be the cause? It is that they are not able to find a plane of cleavage. Okay, plane of cleavage, the placenta has to be separated from uterus and then you can do manual removal of placenta. So it is morbidly adherent placenta, that is placenta accreta. So arranging the blood, taking the consent, I am going to do hysterectomy in this patient, keeping in mind she is multiparous and family would have been complete by this time. So it is retained placenta because MRP has failed to deliver the placenta. Okay. So placenta accreta, rare, where when placenta is directly attached to the myometrium, placental channels have directly invaded the myometrium. Okay. and you cannot take the placenta out. So there is absence of deciduum basalis and Nitterbuck's membrane. This is important. So chorionic villi are invading the myometrium. So I am going to do hysterectomy in this case. So placenta accreta. When the chorionic villi invade the superficial layer of myometrium, it is accreta. When it is invading the full thickness of myometrium, it is increta, and up to serosa percreta. So in all these cases, hysterectomy is the better answer. In primi gravida for accreta, you try to remove as much as placenta, and if you are able to achieve the uterine contraction, then it's okay. But if she is still bleeding, then you have no choice than to do hysterectomy even in primi gravida patient. Primi gravida is brought. Always when term brought is written, that means condition of the patient is not good. In active labor, she looks exhausted. History of thigh handling. Whenever there is a thigh handling, always do immediate cesarean, whether the fetus is dead or alive, because you do not know how much time she has been in labor, and it is a case of usually obstructed labor where there is thinning of the lower uterine segment. Okay, no role of destructive, no role of vaginal delivery. Immediately call your team, take the consent, call the anesthetist, shift the patient to OT, arrange the blood, and perform laparotomy followed by a cesarean section. So fetal heart is not localized. Don't waste your time in doing an ultrasound. Nothing. Even if you are not able to feel the fetal heart, the fetus is dead or alive, uterus is intact or rupture, always laparotomy is your answer to such question. Where thigh handling is written, patient is brought, she is in shock, and fetal heart rate not localized, I am not going to do any wait and watch, and I am going to do a cesarean section. I just forget to mention one option, that is immediately laparotomy followed by cesarean section. So immediate laparotomy followed by cesarean section. All of the following regarding non-scalpel vasectomy are correct except, okay, so it's a method of male sterilization usually done by NSVT technique, non-scalpel vasectomy. Sexual function usually following healing is rarely affected. This is true. Hematoma occurs in 5% of the cases. True. Recanalization is possible. True. Sterility immediately after vasectomy? No. Wrong. Backup method should be used for 3 months. Backup method is used for 3 months. Okay. Failure rate of vasectomy is 0.15 per 100 women year. So this is the male sterilization vasectomy, and it is done by no stitch or no scalpel technique, and this is the vast difference which is being cut. Usually surgeons are doing this vasectomy. Fine. Now, what is the karyotype of complete mole? Is always diploid, and abnormal chromosomes are paternal in origin. So between the complete mole and partial mole, the karyotype is diploid, 90% 46XX, 10% 46XY. Here it is triploid, 69 XXX or 69 XXY. Number 2, presence or absence of fetal tissue. It is absent, it is present. Here only grape-like vesicles. Here grape-like vesicles and fetus both. So it behaves like missed abortion. So abnormal chromosomes, friends, always remember it is derived from the father, paternal in origin. So let me just explain, this is important. In case of complete mole, this is empty ovum. It gets fertilized by a sperm which has 23X chromosomes. After fertilization, the chromosome of the sperm duplicates upon itself. So कुछ abnormal हुआ है against nature because ovum is empty. Usually one set of chromosomes is derived from the mother and one is from the father. यहाँ पे जो है ovum तो empty है, तो जो sperms है वो fertilize कर रहा है but वो ही duplicate हो रहा है. So कुछ तो हुआ है. So this is just vesicles. So it is monospermy. एक sperm ने ही fertilize किया है ना, but abnormal chromosomes are paternal in origin, derived from the father. 10% cases it is 46XY, 90% cases 46XX. तो उसमें क्या है कि ये empty ovum है but it gets fertilized by two sperms, 23X and 23Y. So ये हो गया dispermy. And abnormal chromosomes are derived from the father. So 10% it is 46XY. ठीक है. अब पार्शियल मोल में क्या है? पार्शियल मोल में ये ओवम है जिसको 23X क्रोमोसोम्स हैं. इट गेट्स फर्टिलाइज्ड बाय टू स्पर्म्स, सो इट इज ट्रिप्लॉइड. 69XXX. This is partial mole. So abnormal chromosomes are derived from the father and it is dispermy in partial mole and monospermy in complete mole. Which of the following is correct in order of pap smear? Question from INI CET. कौन सा correct sequence है? For pap smear you can write your answers in the chat box. सबसे पहले पैप स्मीयर हम लेते हैं. जब सबसे पहले यू प्लेस द वेजाइनल सिम स्पेक्युलम एंड एंटीरियर वेजाइनल वॉल रिट्रैक्टर. वैसे हम लोग कस्कोस से लेते हैं, ठीक है, बट अगर आप सिम्स और यूज़ कर रहे हो तो सबसे पहले रिट्रैक्ट करोगे वेजाइनल वॉल. देन आफ्टर दैट यू टेक अ स्क्रैपिंग from ectocervix and from the squamocolumnar junction. Then prepare the slide and then fix the slide. So answer is A, C, D and B. This is the correct answer. A, C, D and B. ठीक है. सबसे पहले prepare the patient, that is Cusco's or या फिर sim speculum with anterior vaginal wall retractor. Then you take the Ayer's spatula and if you are using a slide method, and then a brush, take it from cervical canal and squamocolumnar junction, 2 slides, fix it with a spray. ठीक है. So that is what is the sequence. Fine. Now this is Ayer's spatula conventional method. आजकल हम liquid paps करते हैं. And this is cyto brush. So इसमें हम 2 स्लाइड्स बनाते हैं, ठीक है, एंड वी फिक्स इट विद 95% इथेनॉल प्लस ईथर. ठीक है. सो दिस इज जॉर्ज पापिनोकुलू एंड इसके नेम पे ही पैप स्मीयर रखा है. पैप स्मीयर इज नेम्ड आफ्टर दिस ग्रेट मैन. दिस इज the sample taken from the cervix. This is cyto brush and this is Ayer's spatula and this is the slide how it is been prepared. Now this is liquid paps, this is the spatula and directly you take the sample and put it in this bottle which contains the fixative. 47-year-old female diagnosed with cancer cervix stage 1B3. What is the best modality of treatment? Stage 1B3. The size of the tumor is more than 4 centimeter. So always it is radio plus chemo. So concurrent chemo radiation is the best answer to this question. Fine. Now what is stage 1B? So you can just revise the staging part. I don't want to take so much of bulk in the questions here. Just stick to the point. Otherwise मैं सिर्फ 2 या 3 ही क्वेश्चन डिस्कस कर पाऊंगी. I wanted to discuss maximum questions possible. That is why जितना required है उतना ही I am explaining. So invasive cancer confined to the cervix. Invasion is more than 5 millimeter depth and the tumor size is more. So here you can go for surgery, but here chemo and radiation. Fine. Now stage wise, if the stage 1, A1, A2, B1, B2 and 2A, it is surgery and followed by radiotherapy depending upon the lymph node status. If it is 1B3 and 2A, which is bulky tumors, they are usually bulky tumors and tissues are very, very friable and bleeding points are so much, so it's better to damage that structures. So concurrent chemo radiation has proven better results than surgery. Okay, then if it is stage 2B, 3 and 4, concurrent chemo radiation and radiosensitizer drug is cisplatin. Fine. So that's all I have to discuss in this session, and the students were wonderful in like sending the replies to the questions. I can just read the chat, and I hope this is useful to you. To cover each and every question and each and every topic is not possible. We look at the 3-4 years pattern, and accordingly I have planned these questions. Now remember the sequence of labor, stages of labor, that is very, very important. Ovarian cancer tumor markers, very important. Histopathological examination, that is again very, very important. Okay, so all the best to you, and thank you very much for being so patiently watching these videos, and you're most welcome for any queries. You can follow me on my YouTube channel, my Facebook, my Telegram, on the Instagram and on the NL channel, LN channels as well. Thank you so much. Bye-bye and have a great time. Do prepare well and give your best results in Obs Gynae. Mind it, Obs Gynae is always a very, very scoring subject. So all the best to all of you, and thank you.